Welcome to ICD-10 Part 2, Drilling Down the Details, presented by the Visiting Nurse Associations of America. This continuing nursing education activity was approved by the Maryland Nurses Association and accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Following the webinar, each registered participant will be emailed a link directing them to an online quiz and evaluation. In order to receive your certificate of completion, you must attend this webinar in its entirety and complete the online quiz and evaluation you receive via email. You must earn at least a 70% on the quiz to receive your CEUs. Please ensure all contact information you enter is correct, as this is where we will email all certificates. We ask that all online quizzes and evaluations are completed by Wednesday, September 16, 2015. Our faculty, Sharon Litwin, has disclosed no conflict of interest. Sharon is a founder and senior managing partner of 5-Star Consultants, a national consulting, education, and coding specializing in home care services since 2003. Sharon has been in the home care and hospice industry for over 30 years. She was also an ACHC surveyor until December 2013 and a former CHAP surveyor, performing Medicare deemed surveys for almost 10 years. In her consulting firm, she assists agencies in providing quality, meeting regulations, managing efficiently, and achieving financial viability. Sharon and her staff perform coding and OASIS reviews, clinical record reviews, do mock surveys, and help agencies across the country stay in compliance. Sharon regularly speaks at national and state associations and does frequent webinars for educational firms on many topics integral to being successful in the home care and hospice industry. Sharon, please go ahead.
Thanks, Heather. Hi, everyone, and thank you for joining me today for part 2 of our series on ICD-10. I don't know if this is how you feel when you're thinking of October 1st coming so quickly. I love the guy's bulging red eyes. I was saying to Heather that this is probably how I felt 6 months to a year ago, and I have been teaching and studying and dual coding and teaching and studying and dual coding so much that I'm dreaming about it. And I think that that's what it takes with this. It takes a while. So for so many agencies, they're just really getting into ICD-10. And all I will tell you is there's some light at the end of the tunnel, because after you do study it, work with it, change your processes, learn it, get comfortable with it, practice with it, you do start to go, oh, okay, this is now making sense. Now, I also said I don't think that it will ever be as fast as ICD-9. I think we will always lose some productivity that we have from ICD-9 with ICD-10, because, come on, if a skin tear has 7 digits and we have to look all of those up to know what to do, it's going to take longer. There's just no question about it. But I think that after 3 to 6 months, people will get much more comfortable with it, for sure. There are a lot of chapters. There are a lot of codes. We're going from 14,000 to 69,000 codes, if you remember me telling you that in part 1. And so, of course, it takes a lot more time, study, practice, etc. So in today's session, we're mainly going to go over diagnosis codes. I'm going through the chapters, but obviously in an hour and a half, I mean, if I was going through all the chapters in detail, I'm really going over a lot of the codes, we would be on for 2 days at least. But because of the hour and a half, I'm trying to hit highlights and common codes. One of the bad things is our ICD-10 grouper did not change from January from the final rule, and we certainly had hoped that it would, because we lost 201 case mix codes in ICD-9, and we were so hoping that as NOC was really working with CMS and, you know, everything was put forward to them, that we would get some of them back, and we didn't. And so that is a lot of our pulmonary, our depression, our other psych, blindness, low vision categories that, when you look at the grouping, those are all high acuity patients, but we lost the case mix codes. So many of you, as many agencies have contacted me, have found that their reimbursement has gone down quite significantly. Their case mix has dropped quite significantly because of this. And so that is a challenge. And you can view the new grouper. Of course, you'll need that in your software system. They should already have that being loaded. So let me try to move that over. I have the little go-to meeting. It's blocking the top of my slides there. Okay, I wasn't sure if you could see that as well, but there we go. Okay, so when we go into OASIS C1 ICD-10 version, which is starting October 1st too, it's only the diagnosis categories that are changed, and it's predominantly just the numbers, and they're all going from even to odd. So like M1010 goes to M1011, M1024 goes to M1025. Because this is coding related, I wanted to address this. We don't have to do the M1024/M1025 anymore. We're using that rarely these days, just for fractures predominantly, but you have no need to put anything in M1025 anymore. We're coding fractures in our regular primary and secondary codes, and 1025 does not have anything to do with payment anymore. It may for case mix adjustment. There isn't a lot of data to say how much that will affect, but you don't need to worry about that. All right, so now we'll go through the chapters. So chapter 1 is, and this will be, kind of boring at times today because I'm really just going through the chapters and the codes, and I'm not a speaker, hopefully, as you know from before, that reads off of the screens. However, a lot of this I will, because I'm going over specific codes and examples. So, of course, this is your generally recognized communicable or transmissible diseases. And this is 2 chapters. It's the A chapter and the B chapter, total chapters for infectious diseases. You are going to use the Z code. Now, the Z, if you recall, Z codes are pretty much like our V codes. They're pretty much aftercare. There's many more, and but a lot of times it is a one-to-one match from a V code to a Z code. The code numbers are different, of course. So Z16 and then dot whatever comes after that, that will be the code that you'll use to identify the resistance, but you won't use it if the code for the infection already includes it. So in other words, if you're putting pneumonia due to MRSA, which is J15212, then you wouldn't use the Z16 code. Now you can see right there, I didn't give the related ICD-9 code, but pneumonia due to MRSA, you can see it is complex because there are so many codes. There are so many digits, I should say. This didn't have the 7th digit, but a 6-digit code. So that's what really takes getting used to, because a lot of the codes are so long. Now also, the excludes one notes in every section is why one of the reasons you really have to look your codes up and not just rely on a match from your software system, because in ICD-9 there may be 1 code, and on ICD-10 there may be 20 for that diagnosis. And the excludes one notes may be very different and give you information that says you can't code these together. So if you have a localized infection, you have to see the body system related chapters. And so that does make it a little complex, but that's why you have to look at excludes one, because you would not code both the code from chapter A and B with that body system localized infection in some cases. Excludes 2 means you can code things together. So if you would see in that yes, it's okay to code a Chapter A infection with a body system localized infection. So those excludes 1 and 2 notes are very critical to pay attention to. And what I'm finding is a lot of agencies are using the software crosswalks that they have in their systems, not looking things up, and that's going to cause a real problem down the line with RTPs, return to provider, from putting incorrect codes in. In other words, if you have 2 in there, that you can't have both of them, or else later on for denials. So you do want to be sure that you have, experts that are doing this and that know how to look up all the notes. You would, if anybody has taken the ICD-10 certification test on the line, you know exactly what I'm talking about, because you know that in order to even pass that test, you have to really pay attention to excludes 1 and excludes 2 notes on every diagnosis. So these chapters include intestinal infectious diseases, TB, bacterial, STDs, viral, hemorrhagic fevers, herpes, viral hepatitis, HIV, and sequelae of infectious and parasitic diseases. If you recall, sequelae equals late effect. So when you think of how we say late effect polio, it would be sequelae. Sequela. Sepsis has gotten easier in some aspects. Urosepsis has been removed, and that was really, when we coded a UTI, it would come up urosepsis. Technically, urosepsis is a non-specific term. We're either going to code now UTI, bladder infection, bloodstream infection, kidney infection, whatever it may be, and so that's why they took urosepsis out. Septicemia they pretty much took out. You're going to just code A419 for sepsis, and that is if it's an unspecified organism, and that includes septicemia. So when you look up the code, you'll find septicemia as one of the clarifying terms under sepsis. It's not there anymore, and it says meaning sepsis, C sepsis. So you can just remember, don't get confused by that, and continue looking for septicemia, because you won't find that. All right. So mostly the sepsis codes in ICD-10 are combination codes. So what you'll have is in ICD-9, you'll have 99592 for severe sepsis, and then either septic shock 78552 or post-op septic shock 99802. And that's what you would use together to indicate septic shock. Well, in ICD-10, it's R65.21, severe sepsis with septic shock, or you go to a T code because it's post-procedural, and that's where you'll find any kind of post-op complications you'll find in the T chapters. The severe sepsis with septic shock is a little confusing because the R chapter is mostly our symptom chapters, and yet that's where it is. So that's one of the ones you'll just have to take note of on a cheat sheet to know that severe sepsis with septic shock is in the R chapter. There aren't a lot of black and white areas in ICD-10, and that is what makes it difficult to learn, and it is very different than ICD-9 in a lot of aspects. And so you will probably be confused by some of this and the amount of time we're spending on each thing, but you can go back, look at each of the notes from each of the chapters, and start looking things up so that you kind of understand it more. There are a lot of combination codes in ICD-10 that you'll see as we're talking today as well. So one of the examples is ICD-9, streptococcal septicemia, is 038.0. That maps to 5 different codes, and 5 different codes in ICD-10. I mean, it's not a one-to-one match, as you'll see continually with ICD-9 to ICD-10. There's not a one-to-one match. How could there be when we're going up so many codes, if you think of it logically? So you'll have A40 for strep sepsis, and then you go into the types of infections. So your fourth digit here would be if it is group A, B, pneumonia, other, or unspecified. So when you look at those types, you can see it's rather similar. And especially, you'll see pretty much all through ICD-10, the 0.9 digit is a lot of times the unspecified. So they didn't take that away from us. They have given us the opportunity to have unspecified, thank goodness, because, you know, for so long, all we've heard is how specific ICD-10 is and how you have to know the very specifics and what happens if you don't get that from the physicians. Well, there are unspecified codes. There are some cases that will cost you money if you're taking a 0.9 code and that's not the case mix. So you don't want to put unspecified, but sometimes there's going to be no choice, of course. Okay, so Chapter 2 are the neoplasms, and that's C00 to D49. Neoplasms, we're still having the neoplasm table. They're pretty much grouped by site, which is called the topography. And then there's the broad groupings for behavior, malignant, in situ, benign. So it's similar. You'll want to use the table as you do in 9. And I have found that it's pretty simple as far as the way it looks as far as getting into the neoplasm table and the structure. And then you're going to use, instead of the V10 codes, which means it's a history of CA, you're going to use the Z85 codes. So you would want a code for the aftercare of the surgery as well as a code for the neoplasm itself. So that sounds familiar. So if you have diagnosis of malignant neoplasm of the breast, your first code would be Z48.3, aftercare following surgery for neoplasm, and then followed by the code for the specific neoplasm if it still exists. So no changes there. You would want to have specifics as much as you can. Now, the malignant neoplasm of an unspecified site of the breast is probably going to be common. Probably we're not going to have a specific site that the neoplasm was in the breast. So that unspecified will be fine. But of course, it would not be fine if you chose unspecified female breast. And all the laterality that you will see in ICD-10, most all of them have right, left, and unspecified. You don't want to be putting unspecified when we're talking about laterality, right or left. And those a lot of times will be rejected, not 100% across, but we need to have, is it right or left? And your clinician's assessments should tell you that pretty easily. If they're not documenting right and left for laterality, they should be doing that anyhow. So the ICD-10 code is C50.911, meaning malignant neoplasm of unspecified site of the right female breast. So you can see again the code is much more complex. You know, every digit means something, and we're getting into that it's an unspecified site, it's the right, and it's a female breast. You would want to always put the additional code to indicate the patient's estrogen receptor status if you have that, and that is Z17.0. It does require that. It's in one of the notes that we need to do that, so you will try to get that information. All right. So you can see, I mean, really big chapters with infections and with cancers. I, probably spend 20 minutes on, but there's so much involved in each chapter that you'll want to really take a look at. Some chapters, such as Chapter 3, which is D50 to D89, I'll give you some groupings because that's the typical places that we will go to. For the nutritional anemias, that's in D50 to 53. when I give you, slides like this, a lot of agencies have turned these into little cheat sheets, hanging in front of them or into a notebook for people to try to look things up quicker if they can't find something. D55 to 59 is hemolytic anemias. D60 to 64 are the aplastic, other, and bone marrow failure syndromes. D65 to 69 are the coagulation defects, purpura, and other hemorrhagic conditions. D70 to 77 are the other disorders of blood and blood-forming organs. D78, intra-op and post-procedural complications of the spleen. Now you can see I said you're going to use the T codes a lot for the post-op complications, etc., but here is post-procedural complications of the spleen, and that's what I told you. It doesn't seem like there's any golden rule for anything in ICD-10. Sometimes it's here, once in a while it's here. So again, that's where you're going to have to really read the notes, and it is why it can be real challenging and take time to look diagnoses up other than our top common diagnoses. D80 to 89 would be disorders with the immune system. So some of our common Chapter 3 codes, vitamin B12 deficiency anemia is D51. Then that has 6 of the 4 character codes, and that's where pernicious anemia is D51.0, and that's where vitamin B12 malabsorption and the dietary B12 is as well. So again, you'll see groupings like that adds to the digits. Your anemia in neoplastic disease is D63.0, and you will code first the neoplasm, which is the C and D chapters we talked about. Your anemia in chronic kidney disease is D63.1, and when I say code first the neoplasm, there may be times where you're really focused just on the anemia, and then you would be coding it first. That's not a set in stone rule either, and the same for anemia and chronic kidney disease. Typically, the CKD or the cancer would go first above the anemia, because so often we're in for both things, and if we're taking care of the patient's cancer or kidney disease as well as the anemia, then that would be coded first. If we're just there for anemia, such as maybe somebody who does more IVs and is just there to give Procrit or whatever, then it may be first. Okay, and then our anemia unspecified. So this is pretty much a one-to-one. If you look at that, we don't know what kind of anemia the patient has. Our Chapter 3 codes in ICD-10 have many more anemia types and specificities than ICD-9, but I know I a lot of times code anemia unspecified in ICD-9. I have for years, and that's 285.9, and that's all we get in H&Ps. That's all we get in the patient's assessment, and so that is okay to use 285.9. Well, that would also be okay to use in ICD-10, the D64.9 anemia unspecified. However, there are so many specific codes that if you have more specificity from the physician, that's when you would use it. Thrombocytopenia is the same thing. I've been coding that an awful lot because I've been doing a lot of the hospice coding. We have a pretty big coding division. We have like 24 RNs that just do that all the time, is review home care and hospice, start of cares, and for home care research and rocks, and review the OASIS, and for hospice review the initial assessments and then do the coding and give documentation recommendations. Well, we know that for things such as these anemias that I'm talking about, potentially we're going to be sending a lot more back as problems for the nurse to query the physician, or for the nurse to document more specifically in their assessments if there are not these unspecified codes, or if there's conflicting information, because there are so many codes. So you're going to see that whether you're using somebody like me with my company who's your coders, or whether it's Sally sitting down the hall in a cubicle doing it, because us as coders are going to have to ask for more specificity a lot. And last time in part 1 and in part 3, we're going to talk a lot about, getting your referral information, because that is so top on your priority list, so that accurate coding can be done and the best reimbursement can be done, and you can avoid RTTs and denials. Okay, so Chapter 4 is endocrine, and we'll be here a lot, obviously. Endocrine, nutritional, and metabolic. It's E00 to E89. If you recall, every letter is used except for U. So, and U, I always like to say this, U is saved by WHO for future use. So the World Health Organization, who set this all up, and we're one of the last developed countries going on to it, has just saved the chapter U, but every other letter in the alphabet is used, A to Z. So E00 to 07 are the thyroid disorders, and that's where you will find hypothyroidism unspecified. E08 to 13, that's our diabetes. We have 5 categories. We'll get into that in a little bit. E11 will be our most common for type 2. E15 to 16, other disorders of glucose regulation and pancreatic internal secretions. Some of these others we won't see often like that. E20 to 35, disorders of other endocrine glands. E36, intraoperative complications of endocrine system. Again, instead of T, it's an E. You may have a T code as well. E40 to 46 is malnutrition. E50 to 64 is other nutritional deficiencies. E65 to 68 is our obesity and hyperalimentation problems. E70 to 88, metabolic disorders. And E89, more post-procedural endocrine and metabolic complications not elsewhere classified. So you can see there's a lot in that chapter. Okay, so our diabetes can be much more specific in ICD-10 than 9, of course. The kind of positive thing about it is, though, that a lot of the ICD-10 codes are combination codes that have the manifestation and etiology already included. So, I'll show you some samples, but, our 250.60, which is followed by 357.2, that's a very common one. Diabetes, type 2, uncomplicated, with peripheral neuropathy, and then you have to code the peripheral neuropathy in diabetes. Well, that's going to be combined in ICD-10, so that does make it easier, I think. You have 5 categories now. In ICD-9, you only have 2 diabetic categories, which is 249 and 250, but now we have 5 categories: primary and secondary diabetes. E08 is diabetes due to underlying condition. E09, drug or chemical-induced diabetes. E10 is type 1. E11 is type 2. And E13 is other. And like I said, predominantly will be in E11, but of course we do see all the other types as well. So some of the way that the codes are set up are similar in all 5 of the categories. E11.3 has ophthalmic codes, and there are 18 ophthalmic codes that are combination codes with diabetes. So you will be using that quite often. E11.4, there are 7 neuropathy codes, and the peripheral neuropathy that we do use a lot, which is, like I said, the 25060 with the 357.2, now it's just E11.42. E11.5 is your diabetes with circulatory complications. And what you'll find is gangrene includes the peripheral angiopathy, so that's E11.52. So, and gangrene, we'll talk about that later. It is a little bit confusing because it's hard to find in ICD-10, ironically. Your foot ulcers are combined with E11.621, which is type 2 diabetes with foot ulcer. And then to get more specific, you would add a 2, or to get less specific, I'm sorry, with other skin ulcer. Now, even though that is a combination code, you still use the additional code for the ulcer. And because this is so new and so important, I'll bring it up now, even though we're going to be talking about it in the L chapter. But when you put that code in, this is a non-pressure ulcer, and it requires your nurses to measure the severity of the ulcer. Is it just to the skin level, to the fat level, to the bone level, necrosis, and I think that there's one other. And so they have to give you that information in the documentation to be able to code the ulcer. So that is definitely something that you have to in-service clinicians on. I'll get into that more when I show you the codes. E1164 is hypoglycemia, and E1165 is hyperglycemia. And then the D11.69, other manifestations, another interesting one is osteomyelitis. We don't see osteomyelitis a lot, but here is diabetic osteomyelitis, and you code that with an M86 code because that's where osteomyelitis is. So first you put in the diabetes, other manifestation. So when if you've been coding ICD-9, you know that in today's world that's a 250.80. Well, now that would be D11.69 followed by the M86 code. So all the osteomyelitis are in the M86. And that should be an E. I'm really sorry about that. That's not a D. As soon as whoops, I can't change it in the slide mode, but as soon as I said that, of course, it's the E code for diabetes. So you'll want to change that on your notes. All right. So maybe you have 3 codes in ICD-9, where in ICD-10 it takes 1. So diabetes type 2 with macular edema and unspecified retinopathy, again, you can have unspecified codes. You would be putting the 25050, which is the diabetes with ophthalmic manifestations, and then you would code the diabetic macular edema 36207, and then you would code background diabetic retinopathy 36201. But in ICD-10, you just have to code E11311, and that is type 2 diabetes with unspecified diabetic retinopathy with macular edema. So once you find the codes, that makes it, I think, a lot easier because it's all there together. It's one code. All right. Of course, I could spend the whole day on diabetes, but moving on. Okay. So Chapter 5 is our mental, behavioral, and neurodevelopmental disorders. So we'll be in this category a lot as well. So F01 to 09, or F01 to 99 is this chapter. F01 to 09 is mental disorders due to psychological conditions. 10 to 19 is our mental and behavioral due to substance abuse. 20 to 29 are the schizophrenias and other non-mood psychotic. Then we have 30 to 39 mood affective disorders. F40 to 48 is anxiety. That's where we'll find that. Stress related. I think you could code me with that right now. Other non-psychotic mental disorders. And my anxiety is heightened by my technological difficulties. We were basically hacked with a crypto virus that has taken over all our files. And so our IT company is still trying to work its magic. So yes, you could definitely code me for the anxiety. And I should have started off saying I'm so sorry. I apologize so much for rescheduling last week. We've just been dealing with this nightmare and still can't get to our files. Okay, F50 to 59 behavioral syndromes associated with the physiological disturbances and physical factors. 60 to 69 are the disorders of adult personality and the behavioral disorders. Then 70 to 79 is the intellectual disabilities. 80 to 89, pervasive and specific developmental disorders. The 90 to 98 are PEDS, and then 99 is unspecified. So it's a big chapter. So some of our common ones, FO1, if you are a hospice on the line, you know that you used to use vascular dementia a whole lot as primary terminal diagnoses, and you can't now. We still have the vascular dementia, and it's FO1. You can still use it. It's just what is the underlying reason for vascular dementia? And so that would be your primary terminal, not the vascular dementia. And so very often that will be sequelae of cerebrovascular disease, which would be a late effect today. Late effect equals sequelae. And so it's probably, let's say, late effect or sequelae of a stroke causing vascular dementia, or atherosclerotic without a stroke. So without behavioral disturbance is FO150, with is FO151. You need to use the code for wandering. That went in effect about last year, I guess, in ICD-9, and that's the case. If they are wandering, it's important to put that because of the danger that is heightened with that. And that is V91.93. It's a V code in ICD-9. FO2 are the dementia in diseases otherwise are classified elsewhere. So that is what you have to use after Alzheimer's, for example. So when you're coding your Alzheimer's, that's first, and then you have your dementia that is with Alzheimer's, so Alzheimer's dementia. Okay, so you'd have G30 followed by FO2, and then, of course, with or without behavioral disturbance, and Z code for wandering. And then FO3 is a broad category for our unspecified dementias. It does include senile dementia and pre-senile, but we do have senile dementia a lot in ICD-9 that is separate from, you know, if you think of 294.20 for our unspecified dementia, then you think of 290.0 for senile dementia. Well, they're grouped together now as F03, and that does exclude senility. Senility is before the diagnosis, and so it's a symptom code, R4181. So what you would have is if it's dementia NOS, not otherwise specified, so it's just your broad dementia without something like Parkinson's or Alzheimer's, then it's FO390 without behavioral and FO391 with behavioral. You know, it's kind of funny because we have gone from 14,000 to 69,000, and yet some of these things I'm telling you, you know, we would use 3 codes in diabetes, and now we're using 1, and, you know, such as with senile dementia and dementia NOS, they're combined. So you can see there's so many other added ones for specificity, and to put that number up so far when there are still a lot of combination codes happening. Major depression is listed as F32, and that can be a single episode. There are 8 different codes where you get your specifics of mild, moderate, severe without psychotic, with psychotic, and other major depressive disorders. So anything that you have that's specified will go into these 8 categories. If we have NOS, plain old depression that we see documented by the physicians all the time, not if the patient tells you they're depressed, but if there is a diagnosis from the physician of depression, then that is F32.9. It's unspecified, so just to keep in mind, again, there are a lot of specific codes for depression now. Obviously, if the patient has had a psych eval, you're going to get more specifics. Other than that, I doubt if we will. And our anxiety, not otherwise specified, is 41.9. So that equals our 300.00. General anxiety disorders are F41.1, and there are many more of those. And then bipolar unspecified is F31.9. And again, if all you have is unspecified, it is okay to use it. I keep reiterating that because I've had so many questions from agencies panicking that they're not going to get the specific information. Well, you can see how many of our common codes I've gone through already, that there are unspecified codes. Again, maybe, we've lost so many of our depression as case mix, for example. I don't know if any of these are case mix or not. I don't think so. But if one of those would be a case mix code and you're not paying attention to what was in the psych eval and just putting the simple thing down for unspecified depression, maybe you would get paid less. All right, Chapter 6 is G00 to G99, and that's the nervous system. So here's where I had said G30 for Alzheimer's. So we have our Parkinson's, our G20. We have our Alzheimer's, G30. We have two specific Alzheimer's codes in addition. G30.0 is Alzheimer's with early onset. G30.1 is Alzheimer's with late onset, and G30.9 is our Alzheimer's unspecified. Physicians are being instructed to document late and early onset, so we will be seeing that more often. If you don't know, you put unspecified. You don't say the patient's 80, so he has late onset, or the patient's 60, so he has early onset. That has to be a diagnosis given. So probably a lot of times it's still going to be G30.9, Alzheimer's unspecified. G35 is our MS. G40 is epilepsy and recurrent seizures. But like it is in ICD-9, that's not our seizure disorder where we have no specific diagnosis. Today we put 780.39 for seizures that don't have an underlying diagnosis, and that will continue as a symptom code as R56.9. If you have specific documentation or diagnosis of epilepsy or any of the other seizure disorders, then you would go to G40. Okay, so there are some chapters I'm skipping over. Chapter 7, diseases of the eye, we do use that a lot, but just for seeing what we can put into 90 minutes, I'm just showing you that it's H00 to H59. The H40 codes are glaucoma. The H54 codes are blindness and low vision, and the H35 codes are macular degeneration. So again, that can be a little cheat sheet for you. And then Chapter 8, we don't use too much, so it's diseases of the ear and mastoid process, and that's the rest of the H chapter, H60 to H95. So now one of our big chapters, Chapter 9, diseases of the circulatory system, I00 to I99. So, we won't use the first couple too often. I00 to O2 is acute rheumatic fever. I05 to 09 is chronic rheumatic heart diseases. Then one of our huge ones, I10 to 15, is hypertensive heart diseases. The next several are huge ones for us. I20 to 25 is ischemic heart diseases. I26 to 28 is our pulmonary heart disease and diseases of pulmonary circulation. I30 to 52 is other forms of heart disease, lots of them in there. I60 to 69, cerebrovascular diseases, are strokes. I70 to 79, diseases of arteries, arterioles, and capillaries. I80 to 89, diseases of veins, lymphatic vessels, lymph nodes, not elsewhere classified. And then a big chapter 490 to 99, other and unspecified disorders of the circ system. Okay, so I10 is hypertension. I can teach you that. You will memorize that one right away. Now, Is it specific? Heck no. Are there a lot of more specific disease diagnoses codes? Yes. But I did have somebody a week or two ago say to me, I just don't know what to do because we're not getting anything more specific than hypertension. How am I going to get all these specific codes from the physician? Well, you're not, so that's when you would put I-10. The notes at the top of this whole section are to use an additional code to identify history of tobacco use, Z87.891, or tobacco dependence, F17, or tobacco use, Z72.0. This is in your chapters both for circulatory and respiratory in the J chapter. Hypertension and CKD, chronic kidney disease, stayed the same. There is a presumed cause and effect relationship. So if you have both diagnoses written, you will code the hypertension and CKD. And that's kidney diseases are N, so CKD is N18. And then, of course, gets more specific per stage. Atherosclerotic coronary artery disease and angina. Okay, so for 14.00, best match? Well, yeah, but there's combination codes. And so atherosclerotic coronary artery disease includes with angina, and not just angina, angina pectoris, so it's diagnosed. It's not just angina unspecified, or without angina pectoris. And so I-2510 is without, so it's CAD without, and I-2511 is CAD with angina. I-20 to 25 are all of the ischemic heart diseases. So many times you're going to have that additional hypertension code. You're going to code that separately. So angina pectoris is I-20, but if it's with CAD as above, then you would not code that separately. Chronic ischemic heart disease is I-25, and then of course it gets much more specific. Ischemic cardiomyopathy is I-25-5. So for acute MIs, our time frame for what is considered an acute MI went down to 4 weeks. If you recall, it was 12 weeks up till about 2 or 3 years ago, and then it went down to 8 weeks, and now it's 4 weeks. We do want to be coding our MIs if it's a STEMI or a non-STEMI MI. And so hopefully the physicians will be documenting this. That's very important to know. ST elevation is STEMI, non-ST elevation is non-STEMI. It's in the I-21 series for the MIs, but that is only if they just had it within 4 weeks of the home care admission. If the MI is older than 4 weeks, then you code I-25.2, old MI, which is like 412 in ICD-9. But if a patient is at 4 weeks, after 4 weeks, and you have to code old MI, but you know they're at that 5-week mark and they're still having symptoms, then you would code chronic ischemic heart disease unspecified with the old MI. So you would code I-25.9 after the I-25.2 if they're still having symptoms. All right. So you do have to differentiate, so you will want to, work with your referral sources to be sure. That would be a classic example of getting a very non-specific documentation to me when I'm doing your start of care review. I'm going to have to send that back, and then you're going to have to call the physician or the hospital, whoever. Of course, that holds up compliance and that holds up cash flow. So you want to try to be proactive and get as much of this info as you can. Other common circulatory codes we use, I-48 is our atrial fib. I-50 is our heart failure code. Now, CMS did say when the grouper came out they were not going to give us a case mix on I-50.9, heart failure unspecified. That equals our 4280, CHF. And that was really disturbing because how often will we be able to get more specific? Well, hopefully more than we do now. We don't get, if it's diastolic or systolic or chronic on acute, we don't get the specifics very often now. Hopefully we will be, but don't panic. If you don't, you can use I50.9, and I've used that 1,000 times with dual coding already. I60 to 69, like I said, is our cerebrovascular diseases, so you're going to find your CVAs there. I73.9 is pretty much equal to 443.9 PVD. I82.401, that is our DVT of our lower extremities. Now, what is that? That's like our 453.40, but it has to be more specific. First of all, it's saying it's acute, and again, you only document if it's chronic with the physician saying that, as it is in ICD-9. But it's acute embolism and thrombosis of unspecified deep veins of the lower extremity. So that would be 453.40. But you see you need laterality, so the right lower extremity is the 1. So it's I82.401. Venous insufficiency, chronic and peripheral, is I87.2. Lymphedema are 457.1. That's I89.0. So I tried to give you as many, crosswalk type codes as I could that are common codes. And like I said, always look them up, because there's excludes 1 note there that says don't code this with something else. There's excludes 2 notes that say yes, code this with something else, and many other directions and many other codes. And so this is just a guide of common codes. So coding your late effects sequelae or sequela. Those are the residual defects that remain after an acute illness or injury. Sequelae is 1, and sequelae are plural. I seem to have a problem with that. So to find the right code in ICD-10, instead of searching for the late effect of a particular illness, you search for sequelae in the alpha index. So it is similar to ICD-9. There are codes. Some of the codes incorporate the etiology and the late effect or sequelae into 1 code, such as aphasia following cerebral infarction. That's I69.320. And then there are others that require 2 codes, 1 for the sequelae or residual, and then the code to describe what caused it. Now, I'm going to give you 2 different examples. You have a seizure disorder, and that's G40.909. When it's paired with the traumatic subdural hematoma, S06.5X9S, the 7th character is the sequela, and the S06.5X9S code shows that the hematoma is no longer active, but was what caused the sequela. Now, when you go over to the middle paragraph of this slide, if the patient has a traumatic subdural hematoma that results in a seizure disorder, and the subdural hematoma still exists at the start of the home health episode, you would hope that would be very uncommon, but let's say it does. Then you would code the active form of the subdural hematoma, S06.5X9D, followed by the seizure disorder, G40.909. That's pretty much the same as ICD-9, but there are very specific rules. So look them up to see which goes first and have your referral information and your assessment detailed and accurate enough so that you know what still exists and what does not, so you know the order. So there are 2 things I want to note, and that is in the S06.5X9D, you see that X. If you remember from Part 1, the X is a dummy placeholder, and it means nothing. So X doesn't mean right or left or top or bottom or in and out. It's just there because you have to have 7 digits in this code in order to put the D, because a lot of people are getting confused and they're asking me, I can't put the D in because it's saying it has to be a 7-digit code and the D is going in the 6-digit code. The reason for that is that dummy placeholder has to be there. D is always a 7th character. It cannot be a 6th or a 5th character. So that's when we use that. It's very confusing till you get used to it. And actually, it's still confusing for me when I have to look up the, more complex 7-digit codes with placeholders and the 7-digit being A, S, or D. It can be definitely confusing. Now, if you had an S there, that would be the sequela. And so the S on the end is something we can use as well as the D on the end. There will be hardly any time at all where you will put in A as the 7th character. I used to say there will be no time, but the coding clinic has made it real vague about what happens if during the home care episode the patient gets a skin tear, and on the research the patient has a skin tear. Well, would we code that A as initial encounter? Probably not, because they've had it in the first episode, and the physician has already given orders for it, and we're putting transderm on it, and now it would be a subsequent. But there may be times where you would have to have an A if it happened during the course of your care, but that's very rare because typically our patients then are seen by the physician, which then makes it a subsequent encounter. So you would just think that you will hardly ever, if ever, use an A. So now there's one exception to that sequencing rule, and that's, of course, if it's a manifestation. So hemiplegia following non-traumatic intracerebral hemorrhage affecting left non-dominant side. What is that? That's our 43822. And now it will be I69.154. Aphasia following non-traumatic intracerebral hemorrhage, I69.120. That's our 43811. If the medical record doesn't indicate left or right hand dominance, the coding guidings now indicate that when it's not available, if the left side of the body is affected, then non-dominant should be used. All right. Chapter 10, diseases of the respiratory system, J00 to J99. J14 to 18 are the pneumonia codes, and there are a lot of them. So you definitely will want to look them up. But again, our 486 code we use for pneumonia frequently is unspecified, and that is J18.9. J40 to 47 are our chronic lower respiratory diseases. COPD, oh wait, no, I'm sorry. That's down below our COPDs. J40 to 42, bronchitis codes. J43 is emphysema. Then we start with J44, our COPDs. J44.9 is pretty much equal to our 496 if we have COPD unspecified. J44.1 is more like our 491.21, COPD with acute exacerbation. And J45 are the asthma codes. I'm not getting into those. That's a huge chapter, and for any of those who took the ICD-10 cert test, I know they had a lot of versions of it, but my version, ooh my, they had a lot of respiratory and a lot of very tricky respiratory about when do you code the emphysema with the chronic lower respiratory, with the COPD, with the pneumonia. You have to really read those excludes one and excludes notes on all the diagnoses in the respiratory system. There are a lot of rules, and there are a lot of changed rules from ICD-9. Chapter 11 is K00 to K95, and that's the digestive system. So K00 to 14 is oral and salivary. 20 to 31, esophagus, stomach, and duodenum. 35 to 38, appendix. 40 to 46, hernias. 50 to 52, Crohn's, other non-infective, enteritis, colitis. 55 to 64, other. 65 to 68, peritoneum and retroperitoneum. Liver is 70 to 77, gallbladder and pancreas are 80 to 87, and then, of course, other. Okay, so two big important chapters I basically skipped over just for time's sake. We're getting now into L00 to L99, Chapter 12, diseases of skin and sub-Q. Okay, so we could take the whole day on this, right? All right, so coding pressure ulcers. Pressure ulcers are combination codes. They're very specific, so you have to become very specific in your documentation. They identify the site The site is the most specific that a lot of times we don't have. Did a clinician document left upper back? So a lot of times the specificity of where the ulcer is has to be documented more thoroughly than it is today, or we'll have to send it back for them to tell us and redocument. It would be a real pain if they had to go out and see it on the patient. So that's something you really want to teach your clinicians to document. The pressure ulcers are the same, or the severity, I'm sorry, stages 1 to 4 and unstageable are the same. Stages 1 to 4 unspecified and unstageable. We don't want to use unspecified, hardly ever. And you do need, you have a lot of L89 codes, and you have to use it to identify all pressure ulcers. So you could have several or many codes down there. L89.122 as an example, pressure ulcer of left upper back stage 2. L89.203, pressure ulcer of unspecified hip stage 3. That's that 0 in the 6th digit. You do not want to do that. Of course you know what hip it is. L89.223, pressure ulcer of left hip stage 3. All right. Coding wounds, trauma wounds. So these are open wounds. So, you know, quite honestly, I don't know, I don't have a lot more on that. This could be a skin tear of the forearm. And I'll tell you, several times when I've been coding skin tears over the last month with dual coding, especially on the hospice patients I'm coding that have a lot, oh my, this is one of the trickiest ones for me because there are so many characters for a simple skin tear. Now, there are many other codes in the S chapter with open wounds and trauma wounds, but if you're looking that could be a very common code for us, and some of the other open wounds, abrasions and things like that, it does take, it's not complex, it's not hard, it just takes time to look them up. So laceration without foreign body of right forearm, S51.811D, that would be our 881.0 code. So that would be a wound and, laceration, abrasion. It gets much more specific in ICD-10. It is in the S chapter. The 1 at the end would tell you, in the 6th digit, the right forearm. The D, actually, it would tell you, the 1 at the end would tell you the right arm, the forearm's ahead of that. And then the D is subsequent encounter. Don't get confused. The S at the beginning doesn't mean it's a sequelae. It means it's in our S chapter, which is where a lot of these are. And then the D at the end is subsequent. That can be real confusing at first because you're thinking, well, S equals sequelae, right? Well, S only equals sequelae when it's in the 7th digit. When it's at the start of a code, it means it's in the S chapter. Rocket science, right? Okay, non-pressure wounds. I brought this up before, and these are still diabetic, arterial, venous stasis ulcers. They didn't really make them a lot more specific. I thought that they were going to, that it would be a diabetic ulcer, an arterial ulcer, venous stasis ulcer, but you just code the underlying reasons with them, and then they're all listed under non-pressure chronic ulcers. Now, you can see I gave you examples here because I want to talk about looking at the severity, the depth of the tissue affected by the wound. Well, what is the big problem with these examples? It's unspecified calf. So that 6th digit, I would imagine, is a 1 or a 2 for right or left. You would never want to put unspecified calf. But here's what I was talking about, how your clinicians are going to have to put whether it's breakdown of skin, which is 1 in the 7th digit, or 6th digit, I'm sorry. 2 is fat layer exposed. 3 is necrosis of muscle. 4 is necrosis of bone. 9 is unspecified severity. You don't want to put that because the clinician is doing an assessment, and we are allowed to code this off of the clinician's assessment. So Majority of the time, of course, you know it's going to be skin or fat. All right, I talked about how you need to train your staff and then train them to document as well. So coding an arterial ulcer in ICD-9 is 440.23, atherosclerosis of native arteries of extremities with ulceration. I've always had kind of a problem finding that code in ICD-9. And then you code the 70712 ulcer of calf. In ICD-10, what you put is I70.232. It's still, an arterial ulcer is still found in the circulatory chapter, which is the I, atherosclerosis of native arteries of right leg with ulceration of calf. So you can see a big difference. Then L97.212 isn't saying it's the ulcer of the calf. It's saying it's a non-pressure chronic ulcer of right calf with fat layer exposed. So those 6 digits tell you it's not a pressure ulcer, tell you it's chronic, tell you it's of the right calf, and has fat layer exposed. So with those 2 codes, we have a lot of information, which is the whole point of ICD-10. All right, Chapter 13, M00 to M99. Might be running a little bit over here. I'm only at M. Of course, I'm going to skip the maternal, child, and peds and congenital chapters. But here's where we have our infectious arthropathies, our polyarthropathies. Our osteoarthritis, unspecified, is M15.0, and all the osteoarthritises are in M15 to 19. Other joint disorders, dentofacial and jaw disorders, connective tissue disorders are in the M30 to 36. Deforming chordopathies, I can never say that, spondylopathies, dorsopathies, and disorders of muscles. They're all in the M codes. Common will be M15 to M19 and M05 to 14. Okay, so I did put a couple of other specifics here: synovium, soft tissue, bone density, osteopathies, chondropathies, and other. Intraoperative and post-procedural, again, some are in M, some are in T, not classified elsewhere. M99, biomechanical lesions, not elsewhere classified. I don't know what that is. Common MS system codes that we'll use is M05, rheumatoid arthritis with the rheumatoid factor, or without is M06, so you want to try to know that. Typically it will be with. M10, gout codes. M15 to 19, like I said, M15 is polyosteoarthritis, and there are 7 4-digit codes for it. M16, example, osteoarthritis of the hip, includes 15 4- to 5-digit codes. Bilateral, due to dysplasia, post-traumatic, and other secondary osteoarthritis of the hip. Lupus is M32 category. Fibromyalgia is M79.7. M81 is age-related osteoporosis without current pathological fractures. M81 is where you'll have your pathological fractures with osteoporosis as well. And you'll have age-related or non-age-related osteoporosis, and you'll have pathological fracture or without pathological. So M81 is a big area. Well, I say that, but look at osteomyelitis, 260 codes. Even though it commonly occurs in diabetic patients, there are no manifestation combination codes with diabetic osteomyelitis. So when it's confirmed that it's due to diabetes, that's when we put the E code first with the .69 and then the appropriate osteomyelitis. But there's no causal that can be assumed. It has to be specified. It's together. You have to be able to include acute or chronic to be able to code osteomyelitis. And then you would code the B95 to 97 to say what infectious agent, like I showed you when we were there. If there's a major osseous defect, you do M89.7, like, similar to how we do today. And then osteomyelitis of the orbit, petrous bone are in H chapters, and vertebrae are in M46 codes. So we don't see the H ones often, but we do see vertebrae. So if you look up M86, you'll be directed to go to M46 if you're looking at vertebrae. Okay, Chapter 14 is the GU system, N00 to N99. That's where our acute and chronic kidney diseases are in N17 to 19. I said that we can assume the HTN and diabetic relationship in CKD yet. N39.0 is like our 599.0. If we don't know the specifics on a UTI, you will use N39.0. If you just know that they're incontinent because they have incontinence not otherwise specified, we use a symptom code, R32. That's like our 788.30. If there's a specified reason for the incontinence, then you do it out of the GU system. We don't get that very often. So you would want to code R32 as urinary incontinence NOS. 15, pregnancy, childbirth, puerperium. I'm not a maternal child nurse, as you can tell. 16 is originated in the perinatal period. 17, congenital. 18 is our symptom chapters, basically, R00 to R99. I've already given you lots of examples. Much more greater specificity than ICD-9, but this is kind of our savior. If we don't have a definitive diagnosis, this is what we use. Fever, headache, pain, malaise, and fatigue. So we have the R category corresponds to a lot of our chapters that we're going through. Some symptom codes are found in the specific body system chapters, and some are in the R chapter. But it's not a direct relationship that's true in ICD-9 and ICD-10, but it doesn't stay the same. Here are some that vary. Example, unspecified gangrene is in our symptom chapter, 785.4, which is really pretty odd. Well, now it's moved to the I-96 codes in Chapter 9, the circulatory system, so that makes much more sense. Difficulty walking that we'd love to use is a symptom code 719.7. That's in the musculoskeletal system, not in the symptom. And in ICD-10, it's a symptom code, R26.2. So you can see that some of them do make sense why they changed them. If you know a more definitive diagnosis, use it. Don't use this. Okay, so a patient with Parkinson's, G20, with dysphagia. Dysphagia is not considered integral to Parkinson's, and so you do code the symptom code for dysphagia, R13.1 with another digit. In cases like this, you would sequence the Parkinson before the symptom code. All right. So there are more specific diagnoses, or not diagnoses, symptoms in this R chapter. For example, there are 6 different options for gait abnormality in R26, and that's equal to our 781.2. However, usually we're going to use other or unspecified for that. We don't have a lot of the detail. Here's some others, nausea without vomiting, edema, anterior chest wall pain. If it's not diagnosed as angina pectoris, then there's where you would go. Chapter 19 is injury, poisoning, certain other consequences of external causes. There are no aftercare codes in this chapter. This is a huge, huge chapter and confusing to look up. These 2 are the ones that take me the longest. They took me too long on the test too, so that it's a timed test, and these just take a long time to look up. S00 to T88. S section has injuries to most part of the body, and you can see them broken out there. You have to have 7th characters for codes. We talked about this in initial encounter, ER, new eval, treatment by new physician, surgery. Subsequent, pretty much us, after active, or sequelae, complications from the condition. Fractures are very different, of course. We have been drummed into our heads, you never, never code a fracture as a acute diagnosis in home care, and now guess what? In hospice, and now we're told code them. So you will use the 7th character extension. Most of the time you'll have D, but I'm going to show you the chart. There's a lot more choices with fractures. Z codes are not to be used for injuries. You're supposed to now code the acute code for the injury to be assigned with the 7th character denoting the reason for the encounter, a D. So this may be confusing if this is the first time that you're hearing it, because it's a complete paradigm shift. So traumatic fracture of the shaft of the left tibia, S82.20, which is unspecified fracture of the shaft of the tibia. A 2 is coded in the 6th digit for left. Then the letter saying the type of encounter would be D for the subsequent encounter for a closed fracture with routine healing. Excuse me, I'm starting to lose my voice. So the fracture codes have from A to F. There are many we don't use. ABC we don't use. D we'll use the most often. Subsequent for closed fracture with routine healing. But then there may be types. Type 1 or 2, 3A, 3B, 3C. Are we ever going to have that in documentation? Well, not too often, and we don't have open fractures that often. But G, D is our most common. G, we may have subsequent encounter for closed fracture with delayed healing. We may have a non-union, which is K. We may have a P, which is malunion. And we may have an S, which is sequelae. So that 7th character can be more than A, D, and S when we're talking about fractures. Our T section categories, big chapter, it does involve injuries. It has burns. It has poisonings, underdosing, toxic effects, trauma, complications of surgical medical care. If you haven't taken the ICD-10 cert test, lots of questions on those. From T, from the poisoning, toxic, external complications, a lot of questions. And you'll want to look at your tables, your gosh, is it called table of poisonings? I can't think specifically, but there's a lot of information there. If it's underdosed, overdosed, adverse effect, poisoning, it's a nice chart, a nice table that can help you easily pick what you need. Chapter 20, external causes of morbidity. This is chapter V00 all the way to Y99. There are 9,624 codes in this section. Injury or cause. How is the injury or health condition happening? What time? What place? Well, I actually looked up one that slipped on kitchen floor while mopping. I think I'm telling the truth. I think I actually saw that. Similar to the E codes, but many, many, many more. Somebody used an example about getting injured on the head with a paintball. So it's very creative. They must have had fun writing those chapters. Chapter 21, Z equals V. So now it's our V codes. A lot of direct matches. 1588, history of falling, is Z91.81. It has some different meanings. You will want to look these up, especially at first, because now Z91.81 can be used for a risk of falling, not just recent falls. Here's our aftercare codes, our surgical, our attention to, our fitting and adjustment, our status, our history. Z codes you will use a lot, just like we used V codes, at the bottom of your, unless it's a surgical aftercare or, well, I guess I shouldn't say that. If you're in just for a Foley, if you're in just for the colostomy, if you're in after surgery, you're still going to use those. Then you're going to use all of the other V codes as we do. So Z43 is encounter for attention to artificial openings, colostomies, trachs, etc. If we're doing something with them, those are our V55 codes. If we're not doing something with them, then it's the status codes, Z93. There are a lot more non-compliance codes, and so you will really want to use a specific non-compliance code when you have that. Z91.11 is non-compliance with dietary regimen. 91.12 is underdosing of medication regimen. 91.120, I like this one, patient's unintentional underdosing of medication regimen due to financial hardship. You need to have notes in your documentation saying that you contacted the physician for all of these things. IV, V5881 is now Z4682, and Foley is V53.6 is now Z46.6. Z47.1 is aftercare following joint replacement. The second code is to say which joint is replaced. So then we would also have Z96.641, presence of right artificial hip joint. We do that now with, what is it, V4364, I believe. So now it's just a lot of digits specifying laterality and the site. Don't use 9, that means unspecified laterality. Of course you know what site that is. Wow, I'm surprised I made it in time. I had to rush through enormous chapters, but hopefully you got some of the pertinent guides of where to go for what and some of our common codes. Well, yes, we can only take the jump. I mean, my goodness, I've been teaching this for so long, and now I just can't even believe it's in less than a month. I'm actually excited for it to start, quite honestly, because the dual coding is killing us. The dual coding, I mean, it takes twice as long. And so it'll be nice to just get into where we're just doing ICD-10. All right, tip of the iceberg. Don't feel that I taught you everything there is to know about ICD-10 coding from this 90-minute session. I actually had a director of a home health agency on one of these webinars asking a Q&A several months back. Why do we need more training? This sounds like you've covered everything that we need. I absolutely, the full disclosure is I did not cover everything you need. Tip of the iceberg. Well, it already is the last minute. If you haven't done a lot, then you really need to look at your training plans now. Our next class is going to show you that last-minute preparations, if you haven't done any of the things, don't panic. You're going to continue doing them after October to get better and better. Now's the time to say, do we have enough training? Do we have enough knowledge in our agency to be able to do this? Use the crosswalks with your top diagnoses to become familiar. Just like I said, look things up because it's very important to see the notes and the rules. If you don't, I just had the ICD-10 official 2016 books shipped to our office yesterday for all of us, and so if you haven't gotten that yet, be sure to order it, or if you have an interactive website like a lot of me and my coders do, I couldn't live without the interactive website because honestly the book takes me too long. So that's something you might want to look at. Educate your referral sources, what information you need. Okay, now you're jumping for joy. It's going to be simple. At the beginning you thought it was going to be horrible, and now you're completely prepared, right? Well, thank you for joining me today, and we have a few minutes for questions if anyone has any.
Great. Thank you so much, Sharon. At this time, we're going to move to the question and answer section of today's call. Before asking your question, please state your name and your agency. I'm going to go ahead and unmute everyone's lines now.
Probably.
Is there any questions?
Probably. I mean, you still have to read through the things to say, is this person hospice appropriate? Do we have the right? Anything that says only hospice, we should do. Right, right.
Does anyone have any questions on the line? If you do not have a question, please go ahead and mute your line as we can hear what's going on in your conversation.
No, I've muted it. I'm hoping, I mean, I have it muted here, so I'm assuming.
Okay. It sounds like we don't have any questions. I'll call for questions.
Okay, well, I know that this may be very overwhelming if you just are hearing it for the first time. If you have done a lot with ICD-10 so far, then hopefully this was a good reference point. So please feel free to email me with questions that you have, because I'm sure that you do have questions. And so it's easier to a lot of times ask your specific question to me on email afterwards. I appreciate you being on with me, and Heather, thank you for having me.
Great, thank you so much. I'd like to take this time to thank you all for joining us during today's webinar. It's your participation and feedback on the post-webinar evaluations that allow VNAA to improve program offerings and activities. As a reminder, please have all quizzes and evaluations submitted by Wednesday, September 16th. I would also like to thank our guest faculty, Sharon, for sharing her expertise, time, and commitment to making this a successful program. Thank you again for your participation, and I hope you have a wonderful afternoon.